A warning, this podcast deals with mental health issues and suicide.
Tonight's big story. Mental health services in New Zealand haven't improved. In fact, some aspects are getting worse.
A new national survey shows mental well-being has declined across all age groups in Aotearoa.
Half of all new mothers in Aotearoa, New Zealand experience mental health distress. And the leading cause of death among pregnant wahine women in Aotearoa is suicide.
The heartbreaking report into New Zealanders' views on mental health has just been released. It's been described as a wake-up call for politicians.
Politicians have definitely woken and are finally making a change. In their sights, the Mental Health Act. In its current form, it's
out of date and inadequate. And if I wanted to be really blunt, I would say it kind of supports a system where we effectively criminalise people who are very unwell and then subject them to quite brutal acts because we can't be bothered developing a better response to mental health.
Kia ora, I'm Amanda Gillies, and today on The Detail, overdue changes to the quote, out of date and inadequate Mental Health Act, the law under which mentally ill people are treated, including those who have been convicted of crimes. What's been kicked to the curb, what will be introduced, and who it will impact. But first, what is in the current Act?
The Mental Health Act is Aotearoa's mental health law. It directly affects over 11,000 New Zealanders a year. The Mental Health Act can be used when someone is severely mentally unwell and it's decided that they need mental health treatment, whether they agree to this treatment or not.
Every 46 minutes a New Zealander goes under this law.
To go under this law, which is often called being sectioned, a person is assessed by a mental health clinician and determined by that clinician and a judge to either not be able to look after themselves or to be a risk to their own or someone else's safety.
But here's the problem. Under this Act, patients can still undergo electroshock treatment and be put in solitary confinement. Yes, this still happens in New Zealand.
Tonight, Checkpoint reveals a new psychiatric facility in South Auckland includes 2 rooms specifically designed to keep patients in solitary confinement. That's despite strong criticism that it's an outdated form of treatment that can cause more harm than good.
This is essentially where someone is put into a bare room with a mattress on the floor and a cardboard toilet, sometimes for up to 2 days.
That's Sean Robinson. He's bipolar and a strong mental health battler who could have faced solitary confinement in his early years.
My life was very chaotic. I was cycling between feeling elated, that sort of upper end of the bipolar cycle, and feeling really, really suicidal.
More on his personal journey later, but first his professional crusade. Sean is the CEO of the Mental Health Foundation, which is recommending a raft of changes to the Mental Health Act, including ending solitary confinement. The new draft bill says it's intended to be a critical safety net for people who may need urgent intervention as a last resort. What's in it? Well, it's a bit of a mouthful, but, among other things, it will establish principles to guide decision-making about compulsory care, enable patients to express their preferences and specify what care they agree to, establish a complaints process, look at how the criminally mentally ill are treated, and reduce restrictive practices such as seclusion.
The irony is that just a couple of weeks ago, the government apologised for abuse of children in state care.
Today I'm apologising on behalf of the government to everyone who suffered abuse, harm and neglect while in state care. Today make this apology to all survivors on behalf of my own and previous governments.
And one of the things that the inquiry into that abuse highlighted was the use of solitary confinement. So we've apologised for doing it to young people, but we still have legislation that allows it to be done to extremely unwell people experiencing mental distress. So it's not okay. It's not okay. It's not therapeutic. It doesn't do anything for someone's recovery and health. It's not good for the staff. I mean, people that go into mental health are there to try and heal and support and create recovery. So, it's pretty traumatic for them.
These people who go to solitary confinement, they're obviously in a very fragile state of mind. What toll does it take when they're put in solitary confinement? Talk me through that experience.
Well, luckily, I haven't had that experience myself, but I think, any of your listeners could imagine if you're highly distressed, and I have been in a situation where I've been highly agitated and distressed and quite confused, feeling like that is frightening, as a person going through it. It's also probably pretty confronting for, people around you, especially people who aren't clinicians. But then to be sort of essentially thrown into a bare cell, and I think the cardboard toilet always sticks in my mind, that it's kind of like, bloody hell, it'd be like being imprisoned. And there's no way in the world that can be good for a person's mental health. I think it's really a containment response from the service, and I'm sure that there are many in services who at times get quite frightened and confronted by the behaviour of patients, especially when the service is really stressed and stretched, as we know mental health services are up and down the country. But yeah, I don't think anybody can imagine that process is actually a health response. It's a containment response.
Those, so that they're dealing with people who are methed up, they're out of their brain, they are synthetic cannabis, they are lashing out, being violent and abusive, and they think they're putting them in there for their own safety and the safety of those around them.
Depending on the level of the individual's agitation, some people just require a mattress on the floor because they'll harm themselves on any sort of furniture. Bottom line is safety in very, very dire circumstances.
What do you say to that?
Yeah, well, again, solitary confinement, it's just containment. It's not a detox facility. It's not somewhere where you can safely and therapeutically bring someone down from whatever intoxication they're experiencing and then properly assess what their mental health needs are. So it's all getting jumbled in together in a system that's massively overstretched. Yeah, I don't blame staff for going, well, can't deal with this. But it's not right. It's not right. Once again, we're doing this because we're not prepared to resource a better system. We would like to see a statutory end date for solitary confinement. We've had
5 years, 10 years.
Yeah, well, look, I think we don't want to be sort of idealistic. The system does need to be resourced and kind of have the capacity and the skills and the change processes to be able to do that. But yeah, 5 years, even 10 years, but having a statutory end date in law. We've had targets before, 2020 we were supposed to have eliminated by 2020. Well, that just slipped by.
It's been and gone.
Yeah, I guess people were distracted by COVID-19, but it just slipped on by. And even, we knew we weren't going to get there. Moving up to it, in 2019, it's clear we weren't going to get there. It just kind of slipped by without any fanfare. So if it's locked into legislation, I think there will be much more incentive for governments, health systems to actually plan and put the resources in place to end that. And so we definitely like to see that.
So if I come to you, though, under the new bill, and I have taken meth, I am agitated, synthetic cannabis, I'm lashing out, I'm violent, what will you do with me? What would be the options then? Yeah,
well, look, as I said, I'm not a clinician.
What would you like to be?
What I'd like to be able to do is, number one, as I said, have you in a purpose-designed detox service, so that, because you really can't tell what's going on until someone is sober. And then I would like to be able to have peer support workers get alongside that person. Let's say it's me, and look, when I was undiagnosed, I used alcohol, as a means of self-medication. So there, by the grace of God, it could have been me, So I would have liked to be put in a safe place to sober up, then have someone who could get alongside me in a much more kind of befriending manner and talk me through my options, guide me with the clinicians who, need to be part of that team to do some kind of clinical assessment. I didn't know I had bipolar for a lot of years, so it was actually empowering for me to get that diagnosis. So, someone to sort of walk alongside that process, and then, if I was very unwell, it's kind of like, what are your options here, Sean? And recognise that I have some ability to have input into that, and also get my family involved, unless
How crucial is that?
Well, I think it's very crucial most of the time. Sometimes family can be detrimental, and the new bill does sort of recognise that and does, make more provision for that. But again, in a very stretched system, consultation with family can often be pretty rudimentary, and it's difficult. It's very difficult. I've recently been supporting a family who have a family member who's been recently diagnosed with bipolar, and their behaviour was very, very disturbing. And so the family did support the police and the mental health system to get their loved one sectioned. Now, on one hand, that meant that person got services, but on the other hand, what the result of that has been is because you can't stay in the system for a very long time unless you are very, very unwell. There are checks and balances. So this person then came off the act, but was so traumatised by the process of losing all control over their life, and was so angry that their family had, in their mind, colluded in essentially having them arrested, that they now want no contact with their family. So, with the best wishes, the best desires for your loved one, coercion can actually really backfire.
So, under the current Act, the system, that's police, courts and mental health services, can take control over someone's life and require them to accept different types of services. Again, Sean warns they can be extreme.
It allows things like electroshock therapy.
Electroconvulsive therapy, or ECT, probably one of the most controversial treatments in psychiatry. If you've seen The One Who Flew Over the Cuckoo's Nest with Jack Nicholson, very negative depiction of ECT.
This won't hurt and it'll be over in just a moment.
Uh-huh. What's that?
Conductant. Open your mouth.
What's that?
This will keep you from biting your tongue.
Well.
Now just bite down on it.
Oh.
That's right. Just bite down.
Huh?
Now bite down on it.
Good. Here we go.
Talk me through, what is electroshock therapy?
Electroshock therapy is essentially using low levels of electric shocks to try and change. I'm not a physician, so, to try and change the kind of brain waves and, I guess, break cycles of mental distress. It is still seen as a legitimate treatment, but, clearly it's pretty extreme. But the Act also allows things like restraint, where someone can be handcuffed. So, one of the critical things is it's taking away people's fundamental freedom and their fundamental human rights.
He says it's all fuelled by a lack of funding and resources, along with the wrong attitude and law.
We end up with this law of these practices because we can't be bothered doing something better. As a society, we're not prepared at the moment to invest enough in mental health to have the alternative types of practices and services. And it becomes a vicious cycle because then staff in hard-pressed situations, turn to these kinds of practices because they feel like they have no other options. Families often turn to the Mental Health Act because they feel that at least their family member will get some sort of service if the system is legally obliged to do it. And even people in distress do say, well, when I'm under the Act, I know I'm going to get some kind of service. Because the services can be in the community, they can be in inpatient care. It's not all about being thrown into solitary confinement and handcuffed, but it allows for those things to happen.
In an ideal world then, how would you like this new bill to look? What do you want it to be?
Yeah, look, I think the bill is moving us in the right direction. You know, we do need to acknowledge that. It is talking about minimising the use of compulsion and all that sort of restraint and those practices that go with it. It is enforcing sort of least compulsion. It has to be the last resort, really. It is making provision for a lot more supported decision making, which is really the key to this, that people who are in distress, if they are supported in the right kind of way, if there's sort of de-escalation of an immediate crisis without using coercion, and if there are people who are trained, and often people who are peers, who have been through a similar experience and can kind of get alongside the person and help them work out their options. That is really how we move beyond this.
The right staffing levels, he says, are crucial.
Fewer New Zealanders are accessing specialist mental health and addiction services due to acute staffing shortages.
The Act is the foundation, as I said, and you need to build something on top of that. You need to build the actual services and systems on top of that. And unless we have more resourcing for supported decision making, unless we actually have staff who are trained in that and who are available, and there's enough of them, unless we have cultural advisors, unless we have family liaison, then you can have the best words on paper that you like and it won't really change anything.
Realistically, though, are you going to get any of those things in the near future?
Well, look, I have to continue to be a, happy optimist. I get pretty ho-ha about things. I get ho-ha that governments go, yeah, we agree with all that, and then just do a tiny bit of it. And I get really ho-ha that there isn't a really accountable plan for how we're going to build all this and over what length of time. But I would have to say that we have had some progress. So the access and choice services that the Labour-led government put in place, they did fill a gap. I think we now have a Minister of Mental Health.
4 years since Jacinda Ardern's government announced $1.9 billion to improve mental health services, many in the sector say there have been few, if any, improvements. But now, for the first time ever, New Zealand has a dedicated Minister for Mental Health. And Matt Ducey comes to the role after a career in the mental health sector.
And one of the things that Minister Ducey initiated when he was in opposition and has driven forward since then is amendment to the Order Act, which requires that there be a plan for mental health. I mean, that was one of the things that made us pretty mad in the previous government, was that the Order Act kind of neglected mental health. Sadly, mental health is a far bigger issue than any government has really acknowledged. I mean, when you think that conservatively about 1 million people a year could benefit from mental health services, let alone from knowing how to manage their thoughts and feelings and their well-being. That's a number that makes most politicians' eyes roll, and we've never really acknowledged the scale of mental health demand and built a system that responds to it. The legislation, we need to get that right. Having an outdated piece of legislation where we use practices that the UN criticises as torture, where we use compulsory treatment to one of the highest levels in the world, where it's inequitable and racist and is applied to Māori and Pacifica far more than other people, where it's not therapeutic. Time for change, I think.
The government has now released a new draft of the law called the Mental Health Bill, and Kiwis have less than a month left to have their say on it.
Yeah, look, do it. One person every 46 minutes gets sectioned under the Act. It affects so many thousands of Kiwis. have your say. Go to the Mental Health Foundation website. We've got guides about how to do that. You've got till the 20th of December. You can put it in a 2-line submission, but have your say. This is very important.
Quick message to the government. What do you say?
Yeah, look, keep pushing through with the reform of mental health. Go even further in this legislation. Ban solitary confinement and then put the services in place.
Realistically, when will this all be actioned? When will we see this new bill?
Yeah, look, it's taken a long time to get through Parliament, but hopefully it will be passed into law, probably the middle of next year. And then we've got the long process of changing the actual practices and getting the investment in services.
For Sean, the endless fight for better mental health services and support isn't just professional, it's personal. The black dog has been in his life for a long time, but he knows when the right services and support are available, it's a life changer.
Well, for me these days, it's not that much of a big deal, but certainly when I was very unwell back in, 25 years ago, it was horrendous. And it built up over years. I started experiencing bouts of significant depression and anxiety in my teens, and then it sort of got worse and worse as I went on. And then by the time I got into my 30s, my life was very chaotic. I was cycling between feeling elated, that sort of upper end of the bipolar cycle, and feeling really having panic attacks, being horrendously depressed, feeling really, really suicidal. So sometimes I look back and I'm absolutely kind of in awe, not of myself, but just kind of like, I can't believe that I came through that, and I now live a really, really rewarding life. And yes, I still do get periods of depression and anxiety. The symptoms still bite me, probably once or twice a year. But I manage that much better, much, much, much better. I don't get really, really unwell in the way that I used to. And I'm in a relationship. I'm a parent. I do a rewarding and very interesting and pretty stressful job. I live a good life. A key thing for me is when I'm starting to feel depressed and anxious, I'm now much better at recognising it. And when I was younger, it was like, oh, that's terrible feelings. I don't want to feel those feelings. And I would literally run as hard as I could away from them, usually into alcohol, which just made things worse, really. Now I kind of go, okay, high depression, don't like you, but, we've been here before. We know each other. I know this will pass. I know what I need to do. And what I do is I double down on all those behaviours. Like even if I'm feeling really stink, I'll make sure that I talk to some people or text some friends or whatever, so I have that connection. I'll make sure that I go for a walk or go to the gym. I can remember being in my garden, deadheading the lavenders when I was really depressed, and I was thinking, I feel terrible, but I know this is good for me. And over a period of probably about 10 days, I usually start to recover. But that sort of being honest that I'm feeling depressed with myself, and then also telling some trusted people, that's huge, because it frees up the energy that I put into hiding it, gets freed up to actually recover. So, so I want that for everybody, really. I also, I'm white, cisgender, middle-class male. It was much easier for me to negotiate the system than for many people. I've never been homeless. I've never been unemployed,
You're one of the lucky ones.
So, yeah. And
Big picture.
And I was very lucky with my clinical support. You shouldn't have to be lucky to be able to manage mental health and still live a good life. And that's what we aim for.
That's all for today. The Detail is a newsroom production supported by RNZ and New Zealand On Air. Thank you to Sean Robinson. This episode was produced by Alexia Russell and Davina Zimmer and engineered by Rangi Powick. And thanks to one of our listeners who asked us to explain what was happening with the new bill. I'm Amanda Gillies. Matua.